All right, welcome. Picture this. You're walking into the emergency department for your very first shift. For a second, it's quiet, but before that pager goes off, before we see a single patient, we need to talk about the core principles that are going to guide every single decision you make in here. So let's start with the big one. This is it. Rule number one, straight from the Oxford Handbook of Emergency Medicine. And look, it's not some complicated formula or a rare diagnosis. It's about that little voice in your head, that gut feeling that says, something's not quite right here. That nagging doubt, that is your most powerful diagnostic tool. Trust me, learning to trust it can literally be the difference between sending someone home and saving their life. Okay, so beyond that gut feeling, there are some other golden rules. And these are not just suggestions, they're the absolute foundation of practicing safely in the ED. You can see a theme here, right? It's all about teamwork and being incredibly careful. Work as a team, seek senior advice, write legibly, recheck drug doses. It's a constant reminder that in this place, you are never alone, and being clear and careful is your best protection against making a mistake. And there goes the quiet. The ambulances start rolling in. The waiting room is filling up fast. This right here is the normal state of things in the ED, a kind of controlled chaos. But the key to managing it all isn't about running around frantically. It's about having a system. The whole department, the whole thing, is built around one single idea: maintaining patient flow. Think of patient flow like a chain. It's only as strong as its weakest link. You've got patients arriving, waiting, getting seen, and then either going home or getting admitted. If any one of those steps gets delayed, the whole system backs up. But the handbook points to one bottleneck in particular: exit block. This is what happens when your patient is ready to be admitted, but there's no bed for them upstairs in the hospital. This isn't just an ED problem. It means the entire hospital is full, and that pressure cooker of a problem lands right at our front door, grinding everything to a halt. So with all these people arriving, how do you create order out of that chaos? Well, this is the tool: triage. It's how we sort patients, not by who got here first, but by who is the sickest. It's a system. Red is immediate. They need to be seen right now. Orange, very urgent, within 10 minutes, all the way down to blue, which is non-urgent. This scale is what ensures the people who are in the most danger get our attention first, no matter how crazy busy it gets. Okay, so your patient has been triaged and now you're at the bedside. You know, besides your brain and your stethoscope, your most important tool is actually your pen. Your notes are everything. They're how you communicate with the next doctor, they're a legal document, and honestly, they're how you organize your own thoughts. And the details matter so much, documenting what you did find and also the important things you looked for and didn't find. Always write out left and right, and for something like an arm injury, you have to note if they're right or left-handed. That context changes everything for their recovery. Clear notes protect you and your patient. So you've seen the patient, you've done your assessment, and you've decided they need to be admitted. Now what? Now comes one of the toughest things for any new doctor: making that referral call. So how do you do it? How do you sound professional and get what your patient needs when the specialist on the other end of the line is just as swamped as you are? Don't worry, there's a formula, and it works. First, introduce yourself clearly, name and grade. Step 2, give them the headline, a really quick, concise summary of the case. Step 3, be direct. Tell them exactly what you want. I'm calling to request admission, or I'd like your opinion on this case. But what if they say no? This is the most important part. Step 4, you stay professional. You do not get into a fight. You simply escalate to your senior staff in the ED. That's what they're there for, to back you up and handle those situations. This example right here shows you why the bigger picture is everything. So you've got an elderly woman with a Colles fracture. That's a common wrist break. Medically, it seems pretty straightforward. But what we do in the ED is just one small piece of the puzzle. Does she live alone? Can she manage at home with her dominant hand in a cast? This is where calling her GP is absolutely crucial. The GP knows her social situation. They know if she has family nearby. That information helps you make a safe plan for her to go home and could be the difference that prevents an unnecessary hospital admission. You're treating a whole person, not just a broken bone. And then, all of a sudden, the normal noise of the department just stops. A single phone call comes through to the charge nurse. The entire feeling of the department shifts. Every routine case, every minor injury is suddenly on hold. A major incident has just been declared. So what is a major incident? Well, the official definition is right there. But basically, it's any event so big that our normal, everyday resources just can't handle it. Every single hospital has a detailed plan for this. There are action cards, specific roles, and your job right now is to know what your role is in that plan before it ever happens. When you're dealing with major trauma, or any critically ill patient for that matter, your approach has to become incredibly disciplined. You fall back on this, the primary survey. It's a system, a process, to find and fix the things that will kill your patient first. You'll notice that little C at the front for catastrophic hemorrhage. That's because stopping a massive bleed is the absolute first priority. Then you move on systematically. Airway, breathing, circulation, disability, exposure. You do it the same way for every patient, every single time. It's what brings order to the most terrifying situations. We've gone from a standard shift to a full-blown catastrophe. But in either one of those situations, there is going to be a moment, probably a lot of moments, where you feel completely, totally out of your depth. It's going to happen. So the question is, what do you do when it does? And let's be absolutely clear about this. Failing out of your depth is not a weakness. In fact, recognizing it is your single most important skill as a doctor. Knowing your limits and asking for help early is what keeps patients safe. The handbook says it perfectly. Do not just try to muddle through. Help is always available. There is always someone more senior to call. Always. And this doesn't just apply to a single difficult case. It applies to the whole job. The pressure day in and day out is enormous. This final piece of advice is maybe the most important one for your own survival in this career. This job is a marathon, and looking after yourself, your own well-being, it isn't optional, it's essential. So please, if you're struggling, tell someone. So the shift ends. The department is still buzzing, but your part is done. You made it. You've navigated the rules, the chaos, the tough phone calls, and all the pressure. You've learned that it's all about listening to your gut, communicating clearly, and knowing when to ask for help. So the only question left is, now that you've seen what it's really like, are you ready to come back and do it all again tomorrow?